I'm Dr. Nasrallah. I'm a professor and chairman of the Department of Psychiatry and Behavioral Neuroscience at St. Louis University School of Medicine. Bipolar depression is the depressed phase of bipolar disorder. As you know, bipolar disorder has mania, hypomania, depression, different phases. Depression of bipolar disorder is called bipolar depression.
Talking about the treatment, what are the latest advances in the management of the pathology from the point of view of diagnosis and treatment?
Well, if you don't mind, before we start treatment, I would like you to ask me, how are they different? Because I told you they look similar, but they're very different.
Yes.
And it's important for your listeners to or viewers to know some of the differences so they can use it in their practice.
Of course, yes, please.
Bipolar depression tends to occur much earlier than unipolar. Okay, so teenage years, early 20s, very common. 90% of all bipolars start their illness before age 29. So young people with depression tends to be bipolar if they are young. Sometimes children, 7, 8, 9, 10 years old. The peak onset of bipolar depression is 19. So that's the maximum, but it can occur before and after. Also, bipolar depression tends to start suddenly and stop suddenly. So episodes are different. The unipolar starts slowly, gradually, over many months and years. Bipolar depression have the opposite of unipolar with regards to sleep and appetite and weight gain. Unipolar, major depression, they have insomnia and weight loss. They don't want to eat at all. Bipolar depression is the opposite. They sleep too much. They sleep 10, 12, 15 hours a day. They can't get out of bed, and they eat too much. Their appetite is very high. So they gain weight instead of losing weight. They sleep too much instead of sleeping too little. These are important differences between them. Bipolar depression patients have a family history of mania, bipolar disorder. It's very important to ask that question of every patient with depression. Has anybody in your family has had bipolar disorder? Is treated with the lithium, with mood stabilizer, has mood swings, different ways of asking.
There is an heritage component,
It's a very, once you have a family history of mania and somebody in the mother, father, uncle, aunts, grandparent, if even one person has mania and the person next in front of you is depressed, you think this may be bipolar depression and just happens to be depressed right now. Bipolar depression also has a lot of anxiety, comorbidity. Like 70-80% of people with bipolar depression have anxiety, panic attacks, generalized anxiety, social anxiety, PTSD, OCD. It's very, very common in bipolar depression compared to unipolar. They also have a lot of substance use. Patients with bipolar depression tend to abuse stimulants like cocaine and amphetamine and marijuana much more than unipolar. Patients with bipolar depression tend to have very successful history. They have a lot of college degrees. They're artists. They're creative. They're musicians. They're very productive. Whereas unipolar, they tend not to have that much education and interest and energy. The reason they're bipolar depressed have such a history is because when they are hypomanic, they feel excellent with a lot of energy. They do much more things. Unipolar never get that episode. Then the postpartum family history of postpartum depression is very common in bipolar. In fact, 95% of postpartum depression, when women get depressed after delivering a baby within a few days or weeks, this tends to be bipolar. So again, that's a good thing to get from the history of the patients. When anybody depressed, ask them, your mother, your sister have had postpartum depression, that's a clue. So there are many, many clues for that. Finally, and it's very common for an adult with bipolar depression to have been misdiagnosed in childhood as ADHD because they have hyperactivity and attention deficit. This is what bipolar can occur in children, and it's misdiagnosed as ADHD. So a history of ADHD can also be a clue for bipolar depression.
And about the treatment? The
treatment is very different. For decades, before we realized how different these two types of depression are, everybody got antidepressants. Now, the antidepressants on the market were approved by the FDA for unipolar depression. We're talking about SSRIs like Prozac, Zoloft, Paxil, and SNRIs like Fexer and Cymbalta and all of those drugs. They're very good for unipolar. But if you give them to bipolar patients, it destabilizes the illness. It disrupts, instead of helping them, it can make them switch to hypomania, switch to mania, switch to a mixed state where they get very angry, depressed and angry. Because bipolar disorder is very commonly associated with irritability. They get edgy, nervous, snappy. And so when you give them antidepressants, they stay depressed and they become angry at the same time. And many people don't recognize that this is now a switch to a mixed state. And there's also rapid cycling. They start getting depression after depression, and they become called treatment-resistant depression. So there are many complications to giving antidepressants to bipolar depression. Only the last 10 years, we've had 2 drugs approved for bipolar depression. The first one was in 2006. It's called Seroquel. FDA approved it because it worked in bipolar depression versus placebo. AstraZeneca is the company that makes it, and about 3-4 years ago, another medication was approved by the FDA called lurasidone, Latuda, and this is made by Sanovian, and both Seroquel and Latuda started out approved for schizophrenia because they are atypical antipsychotic, but both of them have this unique ability to help bipolar depression. And so these are the only 2 approved for bipolar depression as monotherapy. Long ago, about 15 years ago, another company called Lilly showed the FDA that combining olanzapine and fluoxetine, Prozac and Zyprexa, together can also work in bipolar depression. But that's a combination, and very few people use it because it caused a lot of weight gain. Patients gained like 7 kilos in 8 weeks when they in the FDA study. So although it works, it wasn't used, and it's a combo, not a monotherapy. Well, the dose is somewhere between 20 and 120, but nobody uses 120. In the FDA study, they showed that doses of 20 to 60 milligrams per day is just as good as 80 to 120. So I never go above 60. Most of the patients respond to 20, 40, or 60. And in terms of safety features, actually Latuda is one of the most benign antidepressants for weight and lipids and cholesterol and glucose. And so it does not have the metabolic dysregulation that some of the other atypicals have. Seroquel is a good antidepressant for bipolar depression, but it causes more weight gain. The lipids go up, triglycerides go up, it can cause diabetes more than the 2 does. So, and they both work. Seroquel is very sedating, Latuda is not sedating. And so there are times when you use this drug, sometimes you use this drug depending on the patient, they are about finishing the approval from the FDA for use in adolescents. So very soon it will be approved for bipolar depression in adolescents. So far, it's only approved from age 18 and above, although some child psychiatrists use it off-label. But now the company finished those studies, and very soon it will be approved. It's already approved for adolescents and schizophrenia, but they are getting different studies were done for bipolar depression. I did a study of depression in schizophrenia patients. When we did the schizophrenia studies, I was one of the investigators. We noticed that the depression of patients with schizophrenia improved. We were giving Latuda for the psychosis, which was approved by the FDA, but we also noticed that patients who were depressed also were improved with Latuda. So it has antidepressant effect for bipolar depression, but it may also help some schizophrenia patients. But it's not approved for the depression of schizophrenia. We just found that by analyzing the data.